Hi, my name is Daniela Bustamante and I'm from Catholic University and I'm going to talk about intravascular complication of central venous, catheterization by insertion site. Definition. In medicine, a central venous catheter is also known as a central line, central venous line, or central venous access catheter. It's a catheter placed into a large vein. Catheters can be placed in veins in the neck, chest, groin, or through veins in the arms. It is used to administer medication or fluids that are unable to be taken by mouth or would harm a smaller peripheral vein, obtain blood tests, and measure central venous pressure.
This section will present a generic view of the Seldinger technique, which is used to place central venous catheters. If you are familiar with this technique, you may wish to skip ahead to the next section. Many important techniques and subtleties are not included in this section, which is intended only to demonstrate the use of the equipment. Be sure to watch the entire video for a complete demonstration of the procedure. Use the 3 milliliter syringe and the 25 gauge 1-inch needle to place a wheel of anesthetic in the skin. Switch to the 22 gauge 1 1/2 inch needle to place anesthetic into the deeper tissues. Next, attach a 5 milliliter syringe to the 18 gauge 2 1/2 inch introducer needle and advance toward the vessel. Pull back on the plunger as you proceed. Blood will fill the syringe when the vessel is entered. Carefully remove the syringe from the needle, insert the guide wire assembly into the hub, and advance the guide wire into the vessel. Once approximately 15 centimeters of wire have been advanced into the patient, remove the plastic housing, leaving the guide wire in place. You may now remove the needle so that just the guide wire remains in the vessel. Use the 11-blade scalpel to create a small nick in the skin around the guide wire to facilitate passage of the dilator and the catheter. Carefully advance the dilator over the wire and into the subcutaneous tissues with a slight rotating motion, and then remove it. Next, advance the triple lumen catheter over the wire and into the vessel. Finally, remove the guide wire from the catheter and place the end cap over the exposed port. If using a sheath introducer instead of a triple lumen catheter, the technique is slightly different. Fully insert the dilator into the introducer prior to the procedure. Once the guide wire has been placed, insert the dilator and the introducer as a unit into the vessel. Once fully inserted, the dilator and the wire may be removed together.
Applications in medicine. Reasons for the use of central lines include long-term intravenous antibiotics, long-term parenteral nutrition, especially in chronically ill persons, long-term pain medications, chemotherapy, drugs that are prone to cause phlebitis and peripheral veins, plasmapheresis, peripheral blood stem cell collection, dialysis, frequent blood draws, frequent or persistent requirement of intravenous access, need for intravenous therapy when peripheral venous access is impossible. Central venous catheters usually remain in place for a longer period than other venous access devices, especially when the reason for their use is long-standing. For such indication, a Hickman line, a PICC line, or a port I cath may be considered because of their smallest infection risk. A sterile technique is highly important here, as a line may serve as an entry point for pathogenic organisms. Additionally, the line itself may become infected with bacteria such as Staphylococcus aureus and Cauleus negative Staphylococcus.
Courses inferiorly between the two heads of the sternocleidomastoid, ultimately joining the subclavian vein posterior to the clavicle. The carotid artery is located medial and slightly posterior to the vein. Although the internal jugular vein can be a relatively large vessel, up to 2.5 centimeters in diameter, it may collapse if the patient is hypovolemic. The vein may be distended by placing the patient in the Trendelenburg position. In general, the right IJ is preferable to the left, since it lies almost directly above the superior vena cava and right atrium. There are 3 approaches to internal jugular cannulation. For the anterior approach, first establish the location of the sternal belly of the sternocleidomastoid. With your left hand, palpate the carotid artery, which is located medial to the vein. Needle entry occurs along the medial edge of the sternal belly of the muscle at the level of the thyroid cartilage. The needle is held at a 45-degree angle to the skin and is advanced toward the ipsilateral nipple. For the central approach, establish the location of the sternal and clavicular bellies of the sternocleidomastoid. Needle entry occurs in the superior apex of the triangle formed by these muscles. The needle is held at a 45 to 60-degree angle to the skin and is advanced toward the ipsilateral nipple. For the posterior approach, establish the location of the clavicular head of the sternocleidomastoid. Needle entry occurs along the lateral edge of the muscle, 1/3 of the distance from the clavicle to the mastoid process. The needle is held at a 30 to 45-degree angle to the skin and is directed toward the sternal notch. Position the patient supine with the stretcher placed in 15 to 30 degrees of Trendelenburg. The bed should be at sufficient height so that you do not have to bend over or stretch during the procedure. Open the central line kit on a bedside table positioned within easy reach. Before unpacking the kit, put on a face mask, surgical cap, and a sterile gown and gloves. Next, lay out the equipment on the sterile wrapping from the kit. It is helpful to arrange the contents on the table in the order that they will be used during the procedure. Test the guide wire to make sure that it feeds easily through the straightener sleeve and then retract it before proceeding. Pre-flush the ports of the triple lumen catheter with normal saline and leave the cap of the distal port removed so that the guide wire may be advanced through it. Cleanse the skin overlying the entry site with a chlorhexidine applicator.
Pros and cons. Pros. Central venous catheters are used to give long-term medicine treatment for pain, infection, or cancer, or to supply nutrition. A central venous catheter can be left in place for far longer than an intravenous catheter, which gives medicine into a vein near the skin surface. Give medicines that affect the heart, especially if a quick response to the medicine is wanted. Give large amounts of blood or fluid quickly. Take frequent blood samples without having to stick someone with a needle. Receive kidney dialysis if you have kidney failure. A central venous catheter can be left in place far longer than an intravenous catheter, which gives medicine into a vein near the skin surface. Also, a central venous catheter allows a person to receive IV medicines at home. Cons. Central venous catheters need special care. They may require regular cleaning or dressing changes using sterilized techniques. CVCS needs to be flushed regularly with a special sterilized solution to keep them from getting blocked when not in use. Some problems that can occur with a central venous catheter include infection, blood clots, blockage, movement out of position, breakage.
Distal port removed so that the guide wire may be advanced through it. Cleanse the skin overlying the entry site with the chlorhexidine applicator, covering a wide region. Place the sterile fenestrated drape over the procedure area. Note that a large full-body drape should be utilized to reduce the incidence of iatrogenic infection. In this video, the anterior approach is demonstrated. The technique for the central and posterior approaches are analogous, using the landmarks discussed in the anatomy section. If available, bedside ultrasound should be utilized to assist with locating the vein and needle placement. In this chapter, only the blind technique is demonstrated. Palpate the carotid artery with your non-dominant hand and continue to palpate the artery during the procedure in order to maintain a solid fix on its location. Then, using the 3 milliliter syringe with the 25 gauge needle, place a wheel of local anesthetic at the needle entry site, which is medial to the sternocleidomastoid muscle at the level of the thyroid cartilage.
Issue applied in Ecuador. The need for central venous catheterization in Ecuador has become a standard practice in hospitals. Most cases turn up positive results, but in some outbreaks of central venous catheter-associated bloodstream infections were reported in a hospital in Ecuador. Commercially produced ampules of water for injection were found to be contaminated with Burkholderia and Marinanus odoratus. Removal of these ampules yield of tenfold reduction in the incidence of catheter-associated infection. This is one of many reported catheter-associated complications that have occurred in our country.
As you advance until the vein is entered. Once the vessel has been entered, secure the hub of the needle with your non-dominant hand, taking care not to advance or withdraw the needle. Remove the syringe and immediately occlude the hub with your finger to prevent air embolism. Next, insert the tip of the guide wire straightener sleeve into the hub and begin to advance the wire into the vessel with the thumb of your dominant hand. In general, no more than 15 centimeters of wire should be inserted to avoid advancing the wire into the heart. Some guide wires have markings every 10 centimeters along the wire to assist with estimation of depth of insertion. If the guide wire does not pass with ease, stop and recheck for free return of blood from the needle with a syringe. If you are having trouble advancing the guide wire, withdraw it slightly, rotate it a bit, and try to re-advance. It is absolutely essential to never let go of the guide wire once it has been inserted, to prevent migration and loss of the wire into the central circulation. Once the wire has been advanced,
Thanks for your time.